Perfect. Well, good morning, early afternoon to everybody who is joining us. We're going to give a few minutes here and let everybody get logged in. We expect a pretty good chunk of attendance. So like I said, just a few minutes. We'll be very respectful of your time, give you a ton of information, and we will get started here about two after. Okay, well, to start us off, I see a bunch of new names, new faces as well. So really great that everybody could attend. My name is Courtney. I'm with National Contracting Center. I am their strategic partnership manager. We have Brandon with us as well, who is a training manager here at National Contracting Center. And then we have two very valuable guests. We have Bill with the Canadian Medstore and Evie with Advanced Diabetic Supplies. And they're going to fill you guys with a ton of information about why each one of their companies is going to help you provide value to your clients. So we're very happy that you were able to join us today. We have an hour set aside for this webinar. It's also recorded. So if you have to jump off or something comes up, we completely understand that. We would like you to be as interactive as you want to be. You can unmute yourself at any point and talk to us one-on-one, or you can type in your chat and Brandon will filter all those comments and questions to the appropriate people. A few things that we would like to go over before we get started with our two guest speakers are some of the changes that are going to potentially come up in the 2025 Medicare market. I also think that's where you're going to see a huge value from both of these companies that we have on, the Canadian Medstore and Advanced Diabetes Supply Group. And then at the end, we are going to open it up as an open forum for you guys to express any concerns that you might have, answer or ask any questions about the general nature of the business, whatever's on your mind, and just overall tell us what you think. We'd love to hear from you. Make sure that you're getting everything you need from National Contracting Center. So a few of the things that we think are going to come up is, first off, the CMS final rule has increased agent commissions. That's fantastic for you guys. So that commission increase is $100 on new Medicare Advantage sales and a $50 increase on replacement and rollover sales. That's also going to apply to PDPs. So they're going to give you an extra $100 on new enrollments and an extra $50 on replacement and rollover enrollments on the PDPs. That's a huge bonus to you guys. There are a lot of things that have the potential of happening on the FMO side. So being able to have that additional increase in commissions from CMS to the agent level is going to help you with some of your marketing costs that may be impacted by other rules that CMS has put out. So please keep that in mind. The second thing is the Inflation Reduction Act. It's going to cap Part D expenses, which is fantastic for Medicare beneficiaries, that those fees will be capped at about $2,000 per year. That's going to have a big effect. That is going to really have a big effect on standalone Part D drug plans because they don't have anywhere else to absorb those costs. So please keep that in mind. If you're selling med sups in standalone Part D plans, you're going to see a large change in that market. And of course, Medicare Advantage will have some changes because of that Part D cap as well. You're going to see that increased utilization is leaving companies very little to cover their administrative costs. So that's going to tighten some reins as well. And then, of course, the reimbursement rate calculations also came in low. All these things together, they look a lot worse than what they'll probably end up coming to. We think that you are going to see some plans tighten up their purse strings. We think that you are going to see PDP plans become a lot more expensive. And we also see the potential in seeing some non-commissionable plans or even plan exits across the board. So 2025 could really open itself to be a landmark year in changes. As far as the projected average of Part D premiums, I don't know at this point. If we have any information on that, we will make sure that we get that to you guys as quickly as possible. There's just nothing out there yet that gives us a really good read on what we would consider reliable information for estimated Part D premiums. What we do think that you're going to see is, even though there could be a little backward slide on some of the benefits, that Medicare Advantage is going to become a more attractive option than ever compared to a MedSup and a PDP. The PDP costs may really impact Medicare supplement sales and drive a lot more people to Medicare Advantage, which is fantastic. And a huge reason for that is because Medicare Advantage has other ways to absorb what are going to be higher drug costs to the carrier versus the client. And Brandon, I saw a question pop up. I just didn't get a chance to read it.
After you answered the projected average Part D premium, they were asking about a question of non-commissionable Part D.
So yeah,
Question mark.
we think that you're going to see that, and it's not something that's new. There are non-commissionable plans out there currently. SilverScript has a non-commissionable plan, and we think that you'll see more of that. There are even some MA plans that are currently not commissionable. So as we get that information on plans that are not going to be commissionable, we are going to send that information out via email. It will also, based on carrier stipulations, be posted on our website. So we will make sure you have that information available to you so that you can use your time in the most constructive manner possible. Any questions as far as what we think are going to be the 2025 market impacts, at least as of now? Okay, well, again, if you have any questions, please feel free. MAPD increase, very possible, Jacob. That's absolutely possible. The premiums could increase. You can see some of the max out of pockets increase as well. Some of those low MOOP plans that are offered have already been made uncommissionable in certain markets. That could also be something you see more of across the board. So they're going to have to even it out somehow, whether that's a higher max out of pocket, higher premium, or even some non-commissionable plans. Sliding back, Miss Maureen, that's just a tightening of benefits. So, if there's an over-the-counter benefit that might get pulled on a little bit and downsized a little bit to absorb some of the costs to make the drugs more appealing. The $2,000 max out of pocket, it's a nice stopping point. But if they have to pay a huge amount of cost up front and hit that $2,000 very quickly, that's something that the carriers might try to avoid. All right, guys. Well, I am going to hand it over to Bill with the Canadian Medstore. He is going to talk to you about his company and how it can benefit you and help keep your clients' costs down.
Courtney, I appreciate the intro there, and I've been participating on a lot of these calls recently, and as you know, speaking at a lot of the different NABIP events and industry events, and I do appreciate the fact of I do appreciate that you're not as negative as some of the other folks out there. You know, for a little while there was the conversation that this was going to be the Part D Armageddon, the apocalypse of Part D, and largely I think that could be said it's true because the phone's going to ring off the hook. Clients that have typically just kind of stuck with their plan and not really cared about making changes are going to be looking to make those changes this year. And we are going to see some major changes to plans, not only on the Part D side, but also on the Medicare Advantage side. But I actually see that as an opportunity. I think it's going to be a great opportunity for agents who have worked hard to build their book of business and are looking to continue to build that book to service their clients. Granted, it's going to be a really busy year, but I think you're going to be able to cement those relationships because there's going to be a lot of agents who are just going to throw their hands up and say, I'm just not going to do this. And I can tell you that the big call centers and things like that, they're certainly not going to be able to service those clients. So that being said, let me just give you a little bit of background on myself. Unlike everybody on this call, unlike Brandon and Courtney, I'm not an insurance professional. I started my company, the Canadian Medstore, 21 years ago with really no knowledge of health insurance, didn't know much about healthcare, didn't know anything about pharmacy, but I got involved in what's become my lifelong passion now, my lifelong goal of lowering the cost of prescription drugs for individuals because my brother was diagnosed with non-Hodgkin's lymphoma when he was 27 years old, went through a bone marrow transplant. And I can tell you, even over 20 years ago, his anti-rejection medication was costing hundreds of thousands of dollars here in the United States. And we were hearing stories at the time. I'll date myself a little bit, but I was around prior to Medicare Part D even being in existence, back when Medicare didn't have a prescription drug benefit. And we were hearing stories at the time about seniors that were taking bus rides over to Canada to buy their prescriptions. We were hearing stories about caravans of parents with diabetic children who were going from Minnesota or Michigan over to Ontario or Manitoba to buy prescription medications because they were so much less expensive. And we looked into getting my brother's medications, and the medications that were costing thousands of dollars here in the United States were available in Canada for a few $100. And when I say available in Canada, these were the exact same medications. That was what was so surprising to us. These were the same medications manufactured by the same company, usually in the exact same facility, but the medications were labeled, one for sale in Canada for a few $100 and another one for sale in the United States that was costing tens of thousands of dollars. So helped my brother get his medications from a pharmacy in Canada, came back and spoke to my physician friend in Tampa, Florida, where I live. And he said to me, Bill, I write prescriptions every single day and people don't fill them because they simply can't afford them. So kind of deja vu, coming back around again 20 years later, we're hearing the same conversations from people. So we started our company helping folks access medications from licensed pharmacies in Canada. Remember, if you lived in Detroit, Michigan, you could drive 10 minutes away to Windsor, Ontario and fill your prescriptions. But if you lived in Tampa, Florida, you didn't have that geographic convenience. So what we did is we started a company that allowed for folks to order their medications from licensed pharmacies in Canada and then have those medications mailed to the individual here in Florida. Started off with one location in Zephyr Hills, Florida. About 18 months into our existence, Medicare Part D became law, and the phone was ringing, but mostly it was from people saying, hey, thanks for helping us for the last year and a half, but we don't need your help anymore because there's this great thing called Medicare Part D, and I'm never going to have to pay, more than $25 for my prescription medication. Well, we found out pretty quickly that the phone started ringing again about 5 months into the year, and people said, hey, I'm in this thing called the donut hole, and I'm now paying more than I used to pay for my medication prior to me going on this Medicare Part D thing. So we realized very, very quickly is that we needed to educate ourselves on not only Medicare, but we needed to work with professionals in that world. So we started to work with health insurance agencies, health insurance agents, and joining groups like NABIP and things like that. So we knew we were working with professionals, not only to educate ourselves, but also to see that as a lead referral source. And it was successful. We grew from one location in Zephyr Hills, Florida, to 7 locations throughout the state of Florida, helping individuals order medications from pharmacies in Canada. Basically, the reason I'm telling you that story is to kind of give you the evolution of where we came from, how we help people, but also to kind of I'm going to tell you a little bit of a history lesson over the next 5 minutes about kind of how we got to where we are. And I don't mean we as a company, I mean we as a country, because people always say to us, hey, Bill, this is great that I can get my Eliquis from Canada for $70 when it cost me $600 here in the United States. But how is that? Why is it so much less expensive in Canada? So I like to tell that story a little bit so when you're talking to your agents, you can understand it. Talk about a little bit of the statistics. I know I'm preaching to the choir here, so I won't really spend a lot of time on this, but I can tell you that right now, every single dollar we spend, about 20%, 20 cents out of that dollar is going to prescription drug costs. That's probably not, a strange concept to you because you deal with this every single day. But when you're talking to the general public, I don't necessarily know that they understand it. What's so telling to me about these statistics and this slide in particular is that right now we're paying about 20 cents on every dollar for prescription drugs when it goes to healthcare costs. When you go back into the 1990s, when they were discussing the creation of Medicare Part D, we were paying about 7%. And when you go back to the 1960s, when Medicare became law, we were paying less than 2% of our healthcare dollars were going to prescription drug costs. Now, that's very, very telling because as we get a few slides into this, you're going to recognize why I'm saying that's so important. This is one that we could kind of go back to. What you'll notice, and we'll talk about this a little bit with the Inflation Reduction Act. People often talk about, well, we've got this new healthcare program, we've got this new government program that's going to lower costs. And what I've often argued is that the prescription drug benefits or healthcare legislation actually often causes the cost to go up. When we get government involved with these new programs, and we're seeing that with some of the things that are being offered now, we're saying we're going to cap something at $2,000 or we're going to make insulin costs $35, but we're not really doing anything to address the actual cost of care. I don't have a solution to that. I'm just telling you that I don't necessarily know, and I've been doing this for 21 years now, that each time I see some type of a government program that comes out and is supposed to be the end all be all, it actually usually causes our costs to continue to go up. This is the one last statistic I want to leave you with before we start talking about the history of health and prescription drug costs in the U.S. 36 million Americans, this is from Kaiser Family Foundation, in 2022 didn't take a prescription medication because of cost. The reason why that's so important is that what that means is 36 million Americans, that's about 10% of our population. Understand that means that we're not talking about some group of poor people well, yeah, we know that people are impacted negatively, but it's not really impacting me. When you think about that 10% of the population, that means that somebody that you're going to church with, somebody you're working with, somebody that your kids are going to school with, somebody that we know is actually not taking their prescription medications because they can't afford that. And I'm not here to argue that somehow the international systems are better than ours, because I'll tell you right now, when I speak to my international pharmacists, they tell me all the time that if they have a family member themselves or when their family members got sick or were diagnosed with some horrible disease, the United States of America is where they'd want to be for their health care. We do have the best healthcare system and the most access to healthcare than anywhere else in the world. The advances in medical technology really is happening here in the United States. And as Americans, we do have access to the best healthcare there is. The problem is, how can we keep it affordable? How can we allow for individuals to have access to that and not go bankrupt? How do we not go bankrupt as a country and as a society when we keep giving away medications and making a cap of $2,000? The medication costs have not lowered. We still have to pay for those. So I guess that's my only point of that slide. I'm going to tell the story about EpiPen real quick, and I know it's an old story that you've all heard before, but it's just important because it speaks to kind of the way our system is set up. So we all probably remember the EpiPen story. Behind the scenes on the pharmacy side, we saw that the cost was going up over about a 5-year time period. It started off to be a little under $200, and it got to the point where it maxed out at around $800 per pen. Now that was a really big deal because the average American, you probably know, has less than $500 or $1,000 in savings. So if you were that single mom with a child who suffered from a peanut allergy or a bee sting allergy, the EpiPen was something that they needed. They couldn't participate in soccer or Boy Scouts unless they had that EpiPen. So often these families were struggling to pay for those. I say it made big news for a couple of reasons. Number one, it impacted kids. When anything impacts kids, the politicians and the news media love it. So they were talking about the EpiPen story a lot. The other reason is because the politicians saw it as a way to kind of, throw some gas on the fire and have some hearings over these things and look what we're doing to, to lower costs. They didn't really do much to lower costs, but they were at least able to grandstand on that. And I think the other reason why it really made a big difference was, and most folks don't realize this was right around when the ACA started to become law and people started pushing things forward, and employers, 80% of the population gets their coverage through an employer health benefit if they're not on Medicare or Medicaid. What we started to see is employers started switching to high deductible health plans. And why that's important to understand that is because prior to that, the individual was going in and filling their EpiPen and paying a copayment. They were paying a $35 or a $45 copayment. They were already upset that the cost of the EpiPen was high, but they were only paying the copayment, not seeing on the back end what Medicare, Medicaid, or the employer was paying. What we saw behind the scenes is that the drug price started going from $200 to $400 to $600 to $800, but the individual didn't see that because they were paying their copayment. Once their employers switched to high deductible health plans, for the first time, individuals were going into the pharmacy and were having to pay the full cost of the drug because they hadn't hit their deductible yet. So now they were picking up the phone, calling their Congress people and complaining about that. So if there's a silver lining to the whole story, I think it was the fact that individuals started to actually see the cost of care, because the truth is, whether you're a Medicare beneficiary or you get your benefits through your employer, the average person who doesn't work in the industry that we work in doesn't actually see the cost of the prescriptions. They only see what their copayment is. This just goes to show you what we were paying versus what the rest of the world was paying. So when we were paying, the slide shows 600. It actually went up to almost 800 across the board in the U.S. In England, they were paying $69 for the exact same EpiPen. Remember, there was no generic for EpiPen at the time, so they were paying $69 for the exact same EpiPen that we were paying $600, $700, $800 for. The French were paying 100. The Germans were paying the most in the European continent. They were paying $200 for the same medication that we were paying $800 for. If you jump onto the next slide, there was a investigative reporter in Buffalo, New York, who visited 10 different pharmacies in Buffalo, and she found that the average cost of the EpiPen in those 10 pharmacies in Buffalo, New York was $756. She then drove over to Niagara, Canada, purchased the EpiPen from those 10 pharmacies in Niagara, and paid an average of $94. Now, remember, this was an individual without health insurance in Canada, was paying the cash price for the medication in Canada, and paid $94 for the exact same EpiPen manufactured in the exact same facility that 10 minutes away in Buffalo, New York, she paid $786 for. This was just, I'll leave it at this, talking about the EpiPen. There was a gentleman named Alex Azar who became Secretary of Health and Human Services for Donald Trump. Actually was a very, very good secretary. I actually was very afraid when he became secretary, because he did come from the pharma industry, and I was concerned this is definitely the fox guarding the hen house. But Azar did more, I think, for lowering the cost of prescription drugs, or at least calling pharma to the table to say, why are we paying so much more than the rest of the world than anybody else did? And maybe it's because he was the fox guarding the hen house. He knew where all the bodies were buried, but he was able to get some things done. But during his hearing, during his confirmation hearing, one of the senators asked him specifically about EpiPens, and he said, and this is very, very telling to the way our system works. He said, when the patient goes to the pharmacy, they're getting the sticker, they're getting the list price. No patient was ever supposed to see that list price. Basically, what he was saying is people are supposed to pay their $35 or their $45 copayment. They weren't supposed to know that as taxpayers we're actually paying $800 for this medication. And the reason I tell that story is because largely what we're talking about now with the $35 insulin thing, although it's great for our clients right now, it's not really doing anything for the healthcare system in the long run, because the cost of the insulin continues to rise and rise and rise. It's just that the individual is being capped at that $35. And we know that not all the medications are covered. And now those costs are being shifted over to the commercial market, which is eventually going to come back around, and Medicare is going to have to increase those prices or eliminate limited what's covered. So once again, just talking about government programs that are supposed to lower costs, maybe they look good, but they're not really doing anything to address the actual cost of care. So it's important to know about the way that Medicare was formed for all you young folks on here that weren't around prior to Medicare Part D becoming law, and probably none of us were around back in 1965 when they actually passed Medicare. Remember the slide that I showed you? Less than 2% of our overall healthcare spend went to prescription drugs. So back in 1965, when we created Medicare as law, which now we consider to be one of the best programs probably created, when you poll people, most folks will say this is a good government program. It's the one time of your life that you probably look forward to becoming, maybe when you turn 21, and then when you turn 65, you're excited about turning a year older. When they created Medicare, there was no such thing as a prescription drug benefit. It wasn't because they were trying to say we don't want to cover drugs for seniors. It was because it was not a major conversation. Back then, if you had a heart attack, you went to the hospital, in a couple of days you died. You didn't have the medications like Eliquis and Plavix and Xarelto that are keeping us alive for so much longer. We didn't have things like EpiPens. We didn't have the treatments for cancer and things like that. So people weren't living as long, but the pharmacology hadn't come as far. So when they created Medicare, there was no Medicare Part D benefit. When we create Medicare Part D back in 2003, a couple of things happened. Prior to the Bush administration, the Clinton administration tried to change healthcare. One of the things they were going to address was prescription drug prices, but they were basically going and saying we're going to turn healthcare on its ear. We're going to change everything. We're going to really go to more of a nationalized or socialized system, and it failed. When you push forward to the Bush administration, a few things happened. Number one, for the very first time, AARP does a survey of their members, and they ask, what's your number one concern? And prior to that, the concern was always outliving their dollars. For the very first time, seniors, members of AARP, started to answer that their number one concern was actually affording healthcare, specifically prescription drugs. So the Bush administration recognized, although the Republicans hadn't typically been a big proponent of lowering prescription drug price or somehow creating a government program to do that, they saw the opportunity because they saw that the polling was showing that that was a very important issue to seniors. The other thing that happened is that for the first time in almost 50 years, the Republicans controlled the White House. They also controlled the House of Representatives and Senate. So they were able to pass the legislation, kind of like when the ACA was passed through the Obama administration. They controlled all the houses at that point. The Republicans had the same thing there, so they were able to push it through. Interestingly, it only passed by one vote, just like the ACA it did, and it became law. But in order for the Bush administration to get that to happen, they learned from the mistakes of the Clinton administration, and they had to kind of bring on two large groups. One of those groups was the insurance industry, and they went to the insurance industry and said, hey, listen, guys, we got about 40 million people that are on Medicaid, are going to be Medicare and going to be aging into Medicare. We've got a program that you're going to be able to sell everybody a new plan. We're going to call it Medicare Part D. We're going to expand Medicare Part C, which is Medicare Advantage. And so the insurance people said, hey, this sounds great. We're on board. As long as we can sell it and it's going to be subsidized by the federal government, we're on board. But they still had to win over the pharmaceutical industry. Pharma was still a little bit angry because they had agreed to negotiate prices through the Veterans Administration. They said, we're not going to do that. We're not going to get involved because you guys are going to dictate what we are allowed to charge for these medications. So the Bush administration, in order to get pharma on board, said that they would pass the law and they would write into the law that it was illegal to negotiate drug prices. So what that meant is that Medicare, the largest manufacturer or the largest purchaser of healthcare in the United States, was not able to negotiate drug prices. And that didn't change until just recently with the Inflation Reduction Act. But the reason why I tell that story is that the cost of healthcare, the cost of prescription drugs, was never regulated. When you look at everything else, whether it's a knee replacement surgery or treatment for a cold, Medicare says, well, this is our reimbursement level. That's what we're going to do. And when it came to drug prices, it was basically the benchmark became whatever the heck you can charge for it. So prescription drugs ended up increasing, and that's how it went from 7% to now over 20% of our overall healthcare spend. So let's just talk real quickly about ordering medications from Canada and how we can help you. Here's a statistic from the from the Trump administration. You might remember that there was some conversations about an executive order that was going to be passed that would base our Part B, meaning Part B like boy, reimbursement on other countries. They compared it to these 8 countries and said Part B drugs, the top 100 Part B drugs, we found that we were paying 56% more than the other 8 countries. The reason why I think this slide's important is I challenge you to look at basically, if you looked at the countries like Germany, England, France, things like that, I challenge you to say if you were traveling to one of those countries, you'd probably feel pretty comfortable to go in and fill, inhaler for yourself, or to get a Z-Pack or whatever. We're not talking about, apples to oranges, third world countries to where we are. These are all first world countries, and we're still paying 56% more than the rest of the world. So people talk to us all the time about the cost of prescriptions and like, well, can we trust drugs from Canada? We know they're cheaper, but can we trust them? What I tell people all the time is that we're talking about the exact same medication. I'm not talking about going to some kid, getting off the cruise ship and some kids selling chiclets in one hand and Viagra in the other hand. I'm not talking about the cold calls you get or the emails you get from somebody saying you can order your, Viagra online, no prescription needed. I'm talking about legitimate licensed brick and mortar pharmacies in Canada. What I tell you is that when they argue with you that somehow you can't trust the drugs from Canada, I want to let you know that we're importing over $20 billion worth of product every year from Canada. Everything from, meat and poultry and seafood, to Labatt beer comes from Canada. We can certify that those products are safe for consumption, but somehow we can't certify that the EpiPen from the same exact facility manufactured by the same company, one just labeled for sale in Canada is somehow unsafe. It's not true. If you're dealing with a legitimate company that's a brick and mortar licensed pharmacy in Canada, you're going to get the exact same medication that you're getting here in the United States. And this is the last thing I'll leave you with when it comes to the comparisons of a drug. So we're talking about how we can help you with your clients. I looked up the drug Eliquis just because that's the number one request we get from folks that are on Medicare. I looked it up on GoodRx. This is actually kind of a dated slide. The GoodRx price now average monthly cost on Eliquis is about $600 in the United States. The average Part D plan that's going to cover this benefit probably going forward is probably going to be over $60, $70 per month, I would say, as we start to see the changes to Medicare. If you go on to the next slide, Brandon. So that same Eliquis that costs $600 here in the United States is going to cost about $73 in Canada. So that gives you a comparison of how that would help your clients. Now, and we talk about some of the changes that what's going to happen within Medicare. This is what I think is going to happen. I think you're going to see what happened with the ACA is you're going to have 10 individuals that are on a Medicare Part D plan. 9 of them are already upset that they're paying too much for their Part D premium and not getting enough benefit for it. There's going to be that one person out of the 10. It's about 10% of the population that's going to spend more than $2,000 per month. So they're going to have to be covered, right? They can't pay more than $2,000. But in order to offset the cost on that one individual, we're going to have to charge everybody else more. So everybody's premiums are going to go up. Everybody's formularies are going to get a lot more skinny, and everybody's co-payments are going to go up. Understand that under Medicare Part D, the law that creates Medicare Part D says that 2 drugs in every category have to be covered, but they don't regulate where that has to be covered or what tier that has to be covered at. So you're going to start seeing some of those more expensive drugs like Eliquis being covered at a higher premium and at a much higher co-payment probably, which is going to cause a lot of people that are on a Medicare supplement and on a Medicare Part D plan to start looking at Medicare Advantage. That's not necessarily a bad thing, but understand that Medicare Advantage's reimbursement has still been limited. So you're going to see some cuts in that level too. So this is going to be a year where you're really going to want to talk to your clients and utilize some different alternative models. And what I'll tell you is using that example of Eliquis, if you have a client now who has to buy $100 Medicare Part D premium in order to get their Eliquis covered, and they're still going to be paying a $60 or $70 or $80 co-payment on that medication, something that you might want to consider is ordering that same exact Eliquis from Canada for $70 and keeping them in a lower premium Medicaid Part D program. If they're switching to a Medicare Advantage program, maybe their doctors are covered under Medicare Advantage program, but the co-payments on their Eliquis are going to be very, very high, or maybe the Eliquis won't be covered at a good tier on that level. So that's when you might want to consider a company like Canadian Medstore to help you with that. So what I'll leave you with is that we're not going to be the end all be all. But we are going to be a tool in your chest when you run into those issues and you're looking at Medicare Part D this year. Consider Canada as an option, not to replace a Part D plan. We're never going to replace a Part D plan, but when you need to fill in some of those gaps, when you have that individual who calls you halfway through the year and says, hey, this plan was great until this year, I was just prescribed this new drug called Eliquis, and now it's going to cost me $600 until I hit my deductible. Consider, ordering that medication from Canada. The other thing, remember, it's not just Medicare. Folks that are on high deductible ACA plans, folks that are on health shares, things like that, can order that medication from Canada because the cost is so much less expensive. And obviously, it's not just Eliquis. I'm using that as the example today. We've got over 10,000 drugs in our database. So what I would tell you is the joke in our office is if it's advertised on TV or you see it in a magazine or on a pop-up ad, those are the drugs we can help you with. Nobody wants to go to Canada to fill their $4 generic drug. The time that we're going to step in is if there's a commercial with two people sitting in a bathtub together, those are the ones that we're going to be able to help people out with. The drugs that are that you see advertised on TV, the brand name drugs that don't have a generic equivalent, that's where we'll be able to help you. I know I went a little over. I apologize. I suppose we can probably hand it over and then I can answer some questions at the end of the, or provide my information and we'll be able to, obviously answer any questions separately. Thanks.
Perfect. Thank you, Bill. We really appreciate that. Everybody, we did put the pricing brochure for 2024 and the Canadian Medstore in the resources tab of this webinar. So if you click on resources at the bottom of your screen, you'll see a PDF. You guys can feel free to download that. We can also email to you if you have any questions. But we are going to go over to Miss
Courtney, let me just say one thing too, just so when you reach out to us as well, we can provide you with that list. And one thing that's important, I talked to Courtney about this, knowing that this was going to be such a crazy year, we're not just trying to send you to our website or a call center somewhere. We've brought on a team that we call our agent concierge. So what that means is that when you have somebody who needs help, you're going to hand them off to an actual real person who's going to be your representative. So when you say, Mrs. Smith, I'm going to hand you over to Amber or somebody on Amber's team. So there's a real live person that they're talking to and they can keep in contact with you on that. So that's not something that we're just trying to send you to a website somewhere. You're going to have an actual person who you can speak to. So we can follow up with you and explain that all to you. Thanks, Courtney.
Thank you. I appreciate that. Ms. Evie, if you would like to go ahead and get started and talk to us about the different programs you have available for diabetics and how to keep their costs down low as well.
Alrighty then. Thank you, Courtney, and great information, Bill. I think teamwork with helping members, agents are meeting. I think this is going to be a great tool, a great combination together. And hello, everyone. Good morning or good afternoon. My name is Evie Hitson. I am with Advanced Diabetes Supply, and I'm going to share with you how we can support you with retention for clients that you are working with that are living with diabetes. So our support will be based off of your existing book of business and new clients that you're going to be working with that are living with diabetes. A little bit about myself. I am the account executive that works directly with agents that live in Indiana, West Virginia, Missouri, and Kentucky. Don't worry if you are on this call and you're thinking, well, hey, Evie, I don't live in any of those states. Have no fear. There will be a main point of contact for our retention support program for you to work directly with. But just kind of talking about myself. But anyway, who is Advanced Diabetes Supply? We are a home delivery pharmacy that specializes in the diabetes testing supplies, insulin pump supplies, and continuous glucose monitors, also known as CGMs. So keep us in mind for the diabetes monitoring supplies. Use the Canadian Medstore for medications. All we do, Advanced Diabetes Supply, our company, is we work with clients and help them get their diabetes monitoring supplies. So think of it as the equipment, no medications, insulins in one specific category we do, and it's only one brand, and I'll get to it here shortly. But again, think of us as the durable medical equipment supplier for diabetes monitoring supplies. All right. We have been in the business for over 20 years, making us the #1 DME supplier on both Google and Facebook. I went a little bit over about myself, and our focus is to provide you as the insurance agent with retention. And how we'll do that is, let's see. Oh, you know what? Just to, and Courtney and everyone will have a recording of this presentation, but as I mentioned, since I am the account executive that only works with agents that live in my respective or my territories that I'm assigned in, here is a visual aid or a copy of our team. So again, as mentioned, everyone here on this call will have someone to work directly with. But if you are an agent that lives in Indiana, West Virginia, Missouri, or Kentucky, you'll be working directly with me. I'm like your assistant for retention support.
This is also in the resource tab, so you can download that available to you now.
Whoop, whoop. All right, awesome. Thank you, Courtney. All right, so how our agent support program works, it's very simple. You as the agent finds clients that are living with diabetes and sends them over to Advanced Diabetes Supply. That's it. That's all you would have to do. Now, how do you find clients that are living with diabetes? Very easy. You can simply ask each client that you are working with if they monitor or check their blood sugar at home. That's a very straightforward question where you as the agent can get a yes or no. So whenever you're sitting with a client face-to-face at an appointment, or if you're doing a virtual appointment or over the phone, you can ask that client that you're working with, hey, do you monitor your blood sugar or test your blood sugar at home? If the client says yes, you identified a member that's living with diabetes that you are going to be working with no matter what. So that client that you are going to enroll onto the best Medicare Advantage plan that's going to work for their health needs is going to need support, or they will need support with getting their diabetes monitoring supplies covered correctly. That's the bigger picture. Clients living with diabetes need support with getting correct coverage for their diabetes monitoring supplies. Now, another way to identify clients that are living with diabetes is if you're familiar with the medication list, because either way, you gotta cross-reference your client's medication list to put them on the best health plan or Medicare Advantage plan that's going to work with them or work for them. So you might see, and if you're familiar, again, this is just another way to pinpoint who these clients are. If you're familiar, you might recognize the medication Humalog. That's an insulin. So right then and there, you identified a client that's living with diabetes that's going to need diabetes medication, as well as diabetes monitoring supplies to manage their blood sugar levels. All right. Now you identified the client that's living with diabetes during your appointment. However you got that appointment scheduled or however you met with them, that's the biggest thing. And when your client says yes, then you want to move forward with telling your client, hey, you know what? Since you are living with diabetes or since you monitor your blood sugar at home, I work closely with a resource called Advanced Diabetes Supply. They're a home delivery pharmacy, and they help all of my clients living with diabetes with getting their diabetes supplies mailed to their home. I would love to make sure that you are getting correct coverage for your supplies. Can I share your name and phone number with them so that they can take care of you on my behalf? Your client in turn during that appointment might say, yes, that would be great. You are an amazing insurance agent. I would love to, use your recommendation and resource, as well as I'm going to let all of my friends and family members know about you so that you can sign them up onto Medicare plans as well. So again, think of us as an added value to what you're already doing. We're an extension and no cost retention support program. So what other programs, and this is the question, think about it this way, what other programs provide no cost support where you can reach out to someone to help you with retention and make sure that your clients are going to get the full benefit of their health plan for a specific product or disease. So clients living with diabetes, You don't have to worry about them whenever you reach out to us, Advanced Diabetes Supply, because we're going to take care of them for you. As long as we have a contract with the health plan. That's another big piece I want agents to remember. But with the time that we have today, I think the biggest thing for you or everyone here on this call or whoever reviews this recording is identifying clients that are living with diabetes and allowing us to take care of them, have trust, have faith. That way we can make sure that your clients stay on the insurance plan that you selected for them. All right, so your client gave you the okay for us to reach out to them. So you, as the insurance agent, would then in turn let us know that you met with someone that needs support with their diabetes supplies. When we reach out to that client on your behalf, that call might look like something like this. Let's use an example. The insurance agent, Scott, reached out to me. Scott lives in Missouri. If anyone knows who Scott is, a great insurance agent that we have been working with for over 10 years. Scott refers all of his clients that are living with diabetes to us so that we can support him. So Scott let us know he was at an appointment today and his client living with diabetes needs our help. So in turn, we're going to reach out to Scott's client named Janet. And that call might sound like this. Hi, Janet, your insurance agent, Scott, asked our pharmacy to support you with getting your ongoing diabetes monitoring supplies. In turn, Scott's client might say, yes, thank you so much for reaching out. I just met with Scott yesterday, and he did let me know that you guys were going to be calling me or contacting me. And that's pretty much it. Another big thing is to always, this is very important, let your clients know that they're going to receive a phone call from a 760 area code phone number. We're calling from California. We are located on the West Coast, but we also have a bi-coastal location in Florida. But the biggest thing is always let your clients know we're calling from a 760 area code phone number. That way they know it's us, and then we'll move forward with that phone call. All right. Okay, dry mouth here. Okay, what happens next? So once we talk to your client, we work with the client and then also their doctor's office with getting the prescription for whatever supplies that they're going to be needing and using. So every client's going to be different. We'll worry about that. Again, your biggest piece is identify who the client is and let us know who they are so that we can support them. And then we, once we get the prescription from the client's doctor's office and their plan goes into effect, let's say back to that example of Scott referring his client that he met with today, Janet. Let's say Scott's client Janet's plan starts on July 1st. Obviously, he's working with someone today that's going to have a future insurance effective date. So you always want to refer your client the same day that you meet with them, because that's going to allow us to make sure that the client has a smooth and easy transition into their new plan, avoiding hiccups and potential copays elsewhere. So that's the key. But refer the client over, we'll work with them, get a prescription from their doctor. If prior authorizations are needed, there's all these ins and outs that we'll take care of. And then we'll make sure that your client's supplies are shipped directly to their home at no cost. Hopefully that makes sense. Again, if you have any questions, let us know. So now we're all, moving forward with which supplies can you send to my clients. So let's take a look at the hardware. You don't have to remember these products. I'm just going to go over a couple of slides. It's just a visual aid. That way you kind of have an idea of the supplies that we carry. So we carry blood glucose monitors, also known as CGMs. These devices are used for finger sticks. So every client that's living with diabetes, type 1, type 2, they need some sort of device to manage their blood sugar readings. Every client's different, but most of the plans, this is another huge piece, most of the Medicare Advantage plans will cover their own brand. Every plan out there is different. You'll have United Healthcare, they want to cover the One Touch Vario and AccuCheck brand meter. Those are $0, along with the supplies to go along with it. So there's a meter, there's test strips, all of that is $0 copay. Now, if you're an agent and you're thinking, well, yeah, I know these supplies are covered at a $0 copay, it's listed on evidence of coverage. So my clients don't have to pay for their supplies. So why are you here on this call? So we know, and you know, the supplies are $0 copay. However, the question is, and the challenge is, the local retail pharmacies are not providing your clients these supplies at no cost. They're charging them copays in error. An example is a client is on a Medicare Advantage with United Healthcare, and they go to their local pharmacy to go pick up their meter and test strips. And the local pharmacist charged them a $76 copay. But you as the agent and the client, you told the client the supplies are covered, this is a great plan for you, you're going to be good to go. But the local pharmacist doesn't know that part. They're running the insurance claims through Part D. When it comes to the diabetes monitoring supplies, it's very tricky. So we encourage clients to use their favorite pharmacy for their medications and prescriptions. That's what they're great for. But when we talk about the diabetes monitoring supplies, there's a lot of challenges. Supplies aren't billed or processed correctly, meaning your clients are having to pay for something that they can get $0. So that's where we come in. We'll build a plan correctly. All right, we also carry continuous glucose monitors, also known as CGMs. I'm sure a lot of you here are familiar with these terms or products. We carry Freestyle Libre and Dexcom. These devices are great technology for clients living with diabetes. They help them manage their diabetes in a much better way, and they don't have to prick their fingers. So let us know if you're working with members that need support with these supplies. Also, insulin pumps. So if you have clients that tell you, I'm using a pump, they might be referring to an insulin pump. So we carry the brands Medtronic, Tandem, and then also the Omnipod. Medtronic and Tandem pumps, those are a Part B, as in Bravo benefit. And then you have the one insulin pump, the Omnipod. That remains a Part D. But again, you don't have to remember all of this. Just stay connected with us because we can help navigate these questions for your client and make sure that the supplies are billed correctly. All right. All right. So I added this slide last minute. I did this morning because I wanted to at least spread let agents know that we do carry one brand of insulin, only one. It's we don't carry any other medication. So not to add any confusion to this section of the presentation. If you're working with clients that are going on to original Medicare with that supplement and that standalone prescription drug plan, we can support that client with our brand of insulin that we carry if they're using an insulin pump. So Medicare says if a client's using a Medicare approved insulin pump, then that insulin that goes into the pump is eligible and needs to be billed through Part B as in Bravo. So this is support that your clients are going to need, because when you think of a local retail pharmacy, they are set up to bill Part D as in drug. Or even with the Canadian Medstore, I'm pretty sure, and correct me if I'm wrong, Bill, it's all of the medications go through D, or it would be the program that you offer where the cost for medications are much lower. But, and feel free to chime in if that was incorrect. But good? Okay, thank you. Yeah. All right, so Part B only. And this is only for clients that are on original Medicare, supplement, and that standalone prescription drug plan. What next year would look like, it's a little bit scary, but stay connected with your leadership team on the ins and outs of the upcoming changes. But if those scenarios come up, let us know, because this is a challenge for local pharmacies to bill correctly, and we're here to help. But again, keep it simple. If they have diabetes, let us know. We'll take good care of them. Other items we carry through Part D, or that need to go through Part D, no matter what. I threw in the Omnipod insulin pump on this slide again, because no matter what, that one specific brand insulin pump is a Part D as in drug benefit. It is not eligible for Part B coverage, and the insulin that's used with the Omnipod pump will always remain Part D as in drug. We can't get that covered through Part B. That's just a Medicare rule. They said Omnipod is not considered a DME, or it's not eligible for Part B coverage, excuse me. Okay, we carry insulin syringes, pen needles, and alcohol wipes. So if you have clients that are taking insulin, such as that Humalog that I used the example for earlier, the client needs a way to administer the insulin. So the Humalog, let's say you put them on a plan, you see insulin's capped at $35. That Humalog will be capped at $35, but the needles that are used for the insulin, they're sold separately and they're not $35. They're tier 3 and sometimes much higher copays. So you might have clients that say, I'm paying, my needles are very expensive. What can I do? Send them over to us so that we can look into, programs or cash price options for those members. All right, I'm almost done. I hope I didn't confuse anyone yet, and hopefully I didn't bore anyone. So just taking it back a few steps, the bigger picture is staying focused on you as the insurance agent. If you're thinking, what's in it for me? Retention, making sure your clients stay on the plan that you signed them up with, and they're also getting care and support. You're providing an extended service that is not offered anywhere else. It's very unique. Take advantage, and remember, this is for free. You don't have to pay me or any of my coworkers. As long as we have a contract with the health plan, we are going to build a health plan correctly for the supplies that your clients need and that we carry. So very simple. All right, now how to get started. Just kind of recapping what we said in the beginning. First step is, remember, identify who the client is that's living with diabetes during the appointment, or if it's a previous enrollment, then we can still help those members. But if it's a new enrollment, that's the easiest way for you as the insurance agent to never have to backtrack. If you know who all of your clients are living with diabetes on the front end, you never have to think, well, did I help out that client last AEP? So start, sending those clients as soon as you meet with them during the appointment. That way we can support them right away. You know where your clients are, and we'll build a relationship, and you'll grow your book of business because those members are going to remember what you did for them. All right, staying on track. You identified the client that's living with diabetes. Now you need to refer that client's name and contact information over to us. There's multiple ways to do that. On this slide, it's my contact information. So again, this is only going to benefit the agents that live in Missouri, Indiana, Kentucky, and West Virginia. My contact information, that is, will only benefit those agents because we will be working directly together. However, keep in mind, if you live in other states, you're going to be working with my coworkers. So hang tight, and Courtney has that information posted on somewhere, wherever you guys look for that info. But
Resources.
there you go, resources, what she said. So refer your client, multiple ways to do so. You can text us during the appointment, and make sure you have permission for us to reach out to the client. That's very, very important. Follow HIPAA compliance. Text us, you can email us, or you can call during the appointment, call us directly. If we're not available, leave a message with your name as the insurance agent and then the client's name and contact info. Or we have a safe and secure refer a client link, which I'm pulling up mine right now. This is what it looks like. It's straightforward. This is pretty much like my landing page for agents that will be working with me. You just type in the client's information, name, date of birth, mailing address, your name as the insurance agent, and their Medicare info, Medicaid, if they have any. That's straightforward. Safe and secure, if you choose to use that method, that's totally fine. Myself, I tell all of my agents, whatever works for you, works for me. A lot of the times you might be at an appointment where the client doesn't have Wi-Fi, they don't have access to internet. And if you can only send me a text with the client's name, phone number, carrier that you're putting them on to, and the start date, that's okay. as long as the clients are okay with us reaching out, the biggest thing, because we don't want to call your clients and they have no idea who we are, why we're calling, and then when we reach out to the clients, remember, we're name dropping your name as the insurance agent. We're calling on your behalf. So we want to remind these clients that we're working together to provide that personal support and that personal touch. All right, and that's it. We'll handle the rest. Here's the contact info. If anyone needs marketing material support, we have flyers that you can use as a leave behind for your clients to reference to. It's a really great piece to keep handy. I would recommend, if you're out there meeting with clients and just passing the information to members that you're signing up and you're encouraging them to call, I would say maybe 10% of them will actually remember to call. So leave them the flyer, reach out to us. That's the best way we can support you, because if we don't know who the client is, we can't help you. And I think that's it.
Hey, Evie, we have a few questions, if you don't mind. The first one is, what carriers are you guys currently working with? What carriers are you in network with?
So we have the major carriers at this time, most of the major carriers. My recommendation is for whoever asked that question, I don't have the chat pulled up, is stay connected with your respective point of contact, because not only do we have contracts with the major carriers, there's also the regional carriers in specific states, such as like in my territory, and it also crosses over to other states. We can work with Zing, if anyone's familiar with that. If you don't live in that like Midwest, then it's not going to make any sense to you. But the major carriers, UHC, Aetna, Anthem, but there's also other states. So we have a list. If you reach out to whoever you're going to be working with, we have a list of carriers that we can share with you. Obviously, if I just sent it to everyone, it would be 50 states, but it is also posted on our website.
Okay.
Hopefully that helped.
And then there was a question about giving you diabetic client information being a HIPAA violation. Is there anything that you want to speak to on that?
You got to get consent from the client. Remember, never follow or refer a client without their consent. So you can get a verbal consent, and it's within Medicare compliance or HIPAA compliance when you're sitting there at an appointment with the client, letting them know you work closely with the resource and you want to make sure that they get their diabetes supplies covered. We're contracted with a health plan. Can you share their name and phone number with us? And if the client says yes, go ahead and send it. Just make sure you have permission with the client. Never send someone that you think has diabetes and you want us to just call on your behalf, because more than likely the client could potentially get upset, and we don't want that for any of your members. And for us too, we don't want the clients to ever feel like their information just came to us out of the blue,
Makes perfect sense. We have a little bit more of a specific question. There's an agent with a client on Freestyle Libre. Currently, he's paying $73 every 3 months. Do you know, or do you have an example of what that particular cost may be?
Well, I guess, and if the person who asked that question, if you could put in the chat, which carrier is that client enrolled onto? I might be able to answer. If it's a Medicare Advantage plan, I might have a quick answer.
Humana.
Humana, that would be one carrier we don't have a contract with. Our hands are tied. They might have a 20% responsibility, but since Advanced Diabetes Supply doesn't have a contract to work with Humana plans, I don't know what their what the co-insurances would look like. But it might be 20%. So 70 something might sound right. Just make sure, make sure you stay connected with us again, based off of those carriers, because that's very important. But for now, we don't have a contract with Humana, so we can't support any of those members with getting correct coverage.
Well, guys, please continue to ask any questions that you have. I do want to be respectful of your time, so I want to make sure that we have an opportunity right now to thank Evie and Bill for joining us. We really do appreciate you guys and everything you do to support agents and make sure that they have fantastic client retention. So, Bill, Evie, thank you guys so much. If there's anything that you would like to add, I will give you the floor and we'll patiently wait for any questions or comments that somebody may have.
I think, and Bill, I'll let you take over after. I think if anyone here on this call, if I think it would be a good idea to reach out to your main point of contact right now. Send them a text message with your name, your email address, and mailing address. That way, you and my colleagues or myself can stay connected. We can start working together, grow together, and yeah, support each other.
Yeah, thanks, Edie. And just want to let you guys know, if you're not working with Advanced Diabetic Supply, we hear from agents all the time how it's made their life so much easier. So I would definitely encourage you to at least have a conversation with them for sure. And same thing with us. I mean, listen, what I said, we brought on our concierge team. We know that a lot of people talk about going to Canada. I already get my drugs through some online, or I send my clients here or there. I'm not trying to tell you not to do that. We're trying to take it to the next level, try to service your clients the same way you service your clients. Have them have a real person and kind of take that off your plate, but that they're being serviced by someone who's going to do the best thing for them. We had some people ask earlier about the MOOP, and doesn't it make more sense for people to go, just hit their $2,000 maximum out of pocket? Probably. In a lot of cases, you might be right. And we're going to give people that advice to say, listen, you don't want to order from Canada because you're actually going to benefit more by just hitting your $2,000 maximum out of pocket. The thing that we have to remember is we have to take into account the premium. Remember, the premium doesn't count towards the out of pocket. So that's going to be a big number this year. And maybe it makes sense for somebody to buy a less expensive plan and get their medication through Canada, because ultimately that might save them, $1,000 this year. So anyway, keep that in mind. Our staff will do that. We'll help you kind of make that decision and do the right thing for the client. And main thing is, like Evie said, take it off your plate and let us kind of do what we're really good at, so you guys can keep doing what you're really good at. So, and Courtney, thanks for so much for letting us come out today. If anybody needs additional information, reach out to Courtney. She can put you in touch with Amber, who's our concierge lead, and she'll be happy to jump on a call, give you more information, provide you with all the marketing materials you need, and obviously provide you with quotes on medications if you need that.
We really do appreciate it. And again, to all the agents on this call, these are two very reputable companies. They are going to make sure that all of your clients are well taken care of, and they have fantastic points of contact for you as well. So if you have a problem, you're going to be able to get in touch with
Let me
somebody.
turn off this webinar because
And that person was turning off the webinar, but it's all good. We're at the end anyways. So please feel free to reach out to Miss Evie or Mr. Bill at any point. I do have Amber's contact information. So if you have a client that you think is a good fit to use the Canadian Medstore to lower their costs, I can shoot that contact information over to you. As always, we want to thank you all for your hard work. Everything you do is very much noticed, and we appreciate your partnership. And we look forward to hearing from you soon. Have a fantastic weekend.